Canadian Triage and Acuity Scale, CTAS. So the CTAS system was used by hospitals in order to triage patients to facilitate the sickest patients being treated first. Shortly after its implementation in the emergency departments in Ontario, we saw the integration of CTAS into the EMS environment. In the EMS environment, CTAS is not used to triage, rather it's used as an indicator of acuity of our patients. This integration brought with it several benefits, including direction regarding the appropriate destination for patients, enhanced communication among healthcare professionals regarding the time to treatment that was necessary for patients. And it empowered the emergency departments to prepare better for receiving patients from EMS, which means that we can improve the time to definitive care and the time to treatment by facilitating that preparation through the communication. Having everyone speaking the same language, utilizing the CTAS scale, allows paramedics to accurately communicate the acuity of our patients to our receiving facilities. Sometimes our CTAS is part of what directs the appropriate destination. If one references the CTAS field guide, you will note that there is in fact a list of transport requirements linked to each of the CTAS scores that can be assigned between 1 and 5. Having said that, there are other factors that come into play when choosing the appropriate destination, such as bypass agreements, STEMI protocols, so for treating patients that are suffering from myocardial infarction. Perhaps you may have protocols in place for bypassing to access a CT scanner quicker for patients that are having a cerebrovascular accident. These things do tend to occur on local levels because they're based on local needs, local resources, what kinds of hospitals are available, and whether or not you need tiered response, helicopter, and things like that for the transports. So it is important, once again, to know, what's required locally. But again, if you refer to that CTAS manual, you can see some direction based on CTAS assignment for appropriate destination. So again, to emphasize, the communication is a very important piece of the CTAS. By implementing the CTAS in the pre-hospital field, we got the dispatchers, the paramedics, and the people at the receiving hospitals speaking the same language. So that's great. One of the primary benefits of the integration is that communication and its resulting expediting of the treatment required for our most acute patients. So again, going back to the concept of treating the sickest patients first. So in CTAS, we actually have 5 levels, which I did briefly mention. We'll talk about each of the levels here now. So when we look at CTAS level 1, we're looking at patients that require immediate intervention or continuing treatment. So patients requiring active resuscitation. If you're providing ventilatory support for your patient, you're providing CPR for your patient, these patients are definitely a CTAS 1. So if you have a hypothermic patient who's gone VSA as a result, for example, that patient is a CTAS 1. So for CTAS 2, you're looking at patients that require rapid intervention and treatment. A lot of the time, these patients will be patients that have had controlled acts applied in the field. So again, we'll look at the hypothermia. That way we can contrast with a specific condition as we move through the CTAS levels. So a hypothermia with severe symptoms would be a CTAS 2. If we refer to the basic life support patient care standards, we'll see that severe hypothermia is defined as no shivering being present, an unconscious patient with cold, stiff limbs, slow absent pulse and respirations, and no other signs of obvious death. So you will have to differentiate between the severe patient that fits in a CTAS 2 and the severe patient that fits in the CTAS 1. So again, your differentiating factor, are you providing resuscitation? Are you providing active resuscitation? Because with the CTAS, we're looking at time to treatment. So how quickly does this patient need attention upon arrival in the hospital? So obviously, if you're providing active intervention on your patient, then that handoff needs to go reasonably quickly, and they need to be there and be prepared. So moving on to CTAS level 3, these would be patients that could progress to a serious problem. So that serious problem then may require medical intervention. So you don't have a serious problem right now per se, but you recognize, applying your critical judgment as a paramedic, that it could progress, the situation could progress. So again, if we look at our hypothermic patient as the example, we'd be looking at a patient who has hypothermia with moderate symptoms. So moving on then to CTAS level 4, these patients, the need for acute intervention, it's not great. So obviously your CTAS 3 patients, there's more likelihood that they're going to go downhill than your CTAS 4 patients. Your CTAS 1 and 2 patients, they're not doing well to begin with. They've got something, that's reasonably critical going on. They have some ongoing interventions. So as we move up the numbers and the numbers get higher, the acuity gets lower, okay? So as I said, the CTAS 4 patients, the need for acute intervention is not great. And so again, here, if we look at our hypothermic patient, that would be hypothermia with normal vital signs. So certainly those are those patients quite moderate symptoms, and you can refer to Nancy Carolyn to look up, or also pathophysiology book would have some information for you about hypothermia and the specific symptoms. So that's beyond the scope of this discussion, beyond sort of comparing it to the CTAS. So moving on, our final CTAS level to discuss is the CTAS 5. CTAS 5 refers to patients who have truly minor complaints that don't pose any immediate threat to the patient. So these patients are quite okay to wait, even potentially they're patients that you would envision sort of waiting in a waiting room for extended periods of time at the emergency department. So there is, in fact, no hypothermic patient that would fall into the CTAS 5 category, because as we saw, a hypothermic patient who has normal vital signs is a CTAS 4. So in the CTAS 5, to find a comparable injury, a cold injury, we'd be talking about somebody that has cold hands. So if we get into frostbite, those types of cold injuries, then that's something different. But if you have someone that's complaining of just simply being cold, that would be an example of a CTAS 5. So we need to apply an organized approach to our CTAS. It's difficult in the beginning because as your knowledge of paramedicine is expanding, so too is your ability to assess the acuity of your patient. So it does involve a fair bit of sort of memory work, if you will, at the beginning. But the fundamental principle when you're deciding on the acuity level, and therefore the CTAS for your patient, is how quickly they need to be seen. So it's the seriousness or the potential seriousness of the patient's problem. How quickly do they need to be seen when you arrive in the hospital? This is part of the information that you're communicating in your radio report. And remember, it allows for that preparation in the emergency department. So in order to figure that out, we will use an organized approach. So you can see on this flow chart that 4 steps are discussed. So the initial step is a quick look. Then we move into the presenting complaint. And then we're applying modifiers, first and second order modifiers. So that sounds super confusing, but we're going to break it down and make it something that you can use and apply. So looking at each of these step by step, when we talk about the quick look, we're only using this for CTAS 1 patients. These are your patients. These are the ones when we talk about circling the drain. They're critically ill. They're in extremis on contact. So you can tell when you do a look check on this patient, part of your assessment, these are the ones that are setting off those alarms. So these patients, again, requiring rapid intervention. Right? Now, it is important to keep in mind that when you do the quick look test, you can have a patient that passes the quick look, so they're not circling the drain, right? So you do the quick look and you find out they don't fit that category. But maybe down the road, as we get into looking at modifiers and we move down that flow chart, in our process and our organized approach, we start applying modifiers and we find, in fact, that patient is a CTAS 1 because of the application of modifiers. So just because they're not a CTAS 1 on your quick look doesn't mean that they won't be a CTAS 1 later. But you can decide to include them in CTAS 1 at the quick look stage. The next step in our organized approach is going to be to look at the presenting complaint for the patient. So just like the organized approach of doing the quick look first, that quick look step is only for CTAS 1. So too is the presenting complaint only for CTAS 1. So what I mean by that is you're looking at patients whose presenting complaint makes them a CTAS 1. The presenting complaint means that they need care and treatment rapidly upon arrival in the hospital. They need people there straight away. So an example of that, chest pain in a patient who has a cardiac history with signs of decompensation. That would be an example of a patient that would be fitting into potentially a CTAS level 1. And should you be finding that there's evidence of a STEMI, then that may be an example of a situation where there are other agreements in place, bypass agreements and things like that. Those would be those local protocols that I mentioned. So the presenting complaint, if it's so severe that your patient is in fact going to need immediate intervention or continuing treatment, then you can rule the patient in to being a CTAS 1 here. If you've done the quick look and you've assessed the presenting complaint and you've found that neither one of those makes your patient fall into the CTAS 1 category, then what you do is you move on down that chart to the modifiers. So in the modifiers, we have two different categories of modifiers. We have first order modifiers and we have second order modifiers. So the modifiers, what they are is additional physiological and historical information that you apply along with the chief complaint. So in the presenting complaint step of our organized approach, we were looking at the presenting complaint being so severe that we just knew right away these patients need immediate intervention. So the classic STEMI patient, chest pain, cardiac patient is the example that I use there. So but sometimes what happens is it's not so clear, right? So then what we need to do is we need to look at the information we're gathering in our assessment. So about the physiological aspects of what's going on, about the history. So we're gathering this information. So then we look at the modifiers here. So the first order modifiers look specifically at the things relating to ABCs, so your airway, breathing, and circulation, the level of consciousness, and the vital signs of the patient. So the second order modifiers, though, they look at a specific condition or a symptom. Right. So we're looking at the first order modifiers. We are looking at respiratory distress, hemodynamic stability, level of consciousness, and temperature. When we look at the second group of first order modifiers, these include pain, bleeding disorders, and mechanism of injury. So we will have another module that will go more into detail on applying modifiers. So you're going to get into using these modifiers, as I said, when the quick look and the presenting complaint alone is not going to sort out which CTAS category your patient falls into. So you'll be picking up this information during your assessments. And it's important also to remember that some conditions fall within more than one CTAS level. So if you think back to the hypothermia patient we were talking about, that patient fell into multiple CTAS levels. So in fact, we were using modifiers as we went through those initial examples to decide which CTAS level belonged to each patient. So the severe hypothermia patient, the vital signs. Are the vital signs requiring intervention? Are they not requiring intervention? Are the symptoms severe? Has the shivering stopped? Is the shivering present? Are there normal vital signs, abnormal vital signs? So we're starting to apply modifiers and look at more factors there. So again, the modified approach, you're going to be looking at your quick look is your first step. Your second step is looking at the presenting complaint. And the third step, applying the modifiers. So the first and second order modifiers. So paramedics will be applying CTAS and documenting CTAS. We'll be communicating CTAS to the receiving facility as part of our handover, as well as part of our radio reporting. And we will get into how those things occur in subsequent modules.